presenting the process in a patient with the opposite hip kept in flexion and abduction to take it away from the operative limb. The cleaning and draping is started with Savlon. The patient is secured on the fracture table with the ipsilateral upper limb being on the chest of the patient. Cleaning with Savlon is necessary to take off the organic matter because most of the trauma patients have not taken a bath one day before, as would happen in elective case. The cleaning should start from the central part where you are going to do the incision and then move towards the periphery. For a shaft femur fracture, it is useful to clean up till the umbilicus and distally well beyond the knee. In this case, a Steinmann pin is being included in the area where we would drape. Once scrubbing has been done with Savlon 2 times, the Savlon scrub is taken away using spirit. Again, we start from the central area and then move towards the periphery because the periphery is contaminated and we don't want to come back from the periphery to the central area. Don't forget the medial side when you're cleaning on a fracture table, and also once you've done the distal, peripheral and the medial, don't come back to the central area where the surgical exposure has to occur. Once spirit has been applied, you dry the area because betadine would not get painted unless you take away the alcohol from the spirit over the skin. Again, the process remains the same. You start from the center and move towards the periphery. Don't come back to the area of surgical exposure once you have touched the periphery or the medial side of the thigh. Once you've done your Savlon and spirit and dried the area, betadine is to be painted. Savlon was scrubbed, betadine has to be painted so that it gets spread throughout the area which is going to be included into the surgical site. Start from the center, move towards the periphery. In a fracture shaft femur, go up to the umbilicus, much beyond the iliac crest. While positioning of the patient, make sure the gluteal area is free. Distally go well beyond the knee. If you have a pin applied, it may be used intraoperatively to assist in traction or rotation. So don't forget the medial side, and after the medial side, don't come back to the central area. You can see that the C-arm has been covered by a short drape. Once you've done this, your draping starts. You start with the ipsilateral leg. You should have an overlap of around 2 to 3 inches over the cleaned area with your drape, and clip it in an area which is not subcutaneous, meaning in the leg. Don't put your clip on the shin, be a bit lateral, and once your drape is a bit proximal, don't clip your clip on the zone of the CPN. The next drape would come from the opposite side, and it will be a long horizontal drape which would hang more towards your side and also cover the leg on the opposite side. Be careful while passing this drape, it should not touch any other unsterile area. Spread out this drape. You can see that the IV post on the ipsilateral side is just next to the table since the upper limb is on the chest. After positioning these two drapes, the third drape comes through the fracture table, deep to the leg and above the post of the fracture table. You can see that we are not moving the C-arm because we have fixed the position of the C-arm before starting the cleaning and draping, and check both the APL and lateral view, which are coming very nicely in this position. So this is the medial drape which takes away the inguinal area. Take it as a U and clip it with the horizontal drape which was coming proximally. Put your clips in a way that they should not be coming in the C-arm, both in the AP and the lateral view. To complete the draping, we would take another drape in the proximal area from the opposite side and also a long sheet on the ipsilateral side. This long sheet is very useful, especially when we are taking the lateral view. It has to be kept taut, clipped in the proximal side and also clipped at the distal side. Since we have a pin here in this patient, we would anchor the taut sheet in the pin. Again, this clip should be away from your area of work. So there the sheet goes into the pin and is kept on. This drape drops down vertically and helps us in getting our lateral view. So the final drape would come from the opposite side. This is the second drape in the proximal area, and we would also clip it to the IV stand, acting as a partial screen on the same side. So once we've done this, most of our cleaning and draping is done. The thing left is the cover of the C-arm. Normally each packet has two covers. We tend to use only one. So you put in your hand into the drape, invert it and slide it over the top of the C-arm. The inferior one, which is deep to the fracture table, need not be draped because our long drapes will take care of that, as we see. So once I have done this, I would remove my gloves. I normally wear 3 gloves, and after the cleaning and draping, the third glove is taken away. Now we do the surface marking and repeat our C-arm shots, both the AP and lateral view, and mark the position of the trochanter in the AP projection. Next we slide the C-arm into a lateral position. Now you can see that the drapes which are long on the ipsilateral side would help in covering the inferior part of the C-arm. So it gets very well covered since there are 3 drapes on this side and there is no issue of sterility. You can take away the clip on the proximal side so that it doesn't come in the lateral view. So once you've got that C-arm projection well, you can do your marking of the lateral projection of the femur using a wire and put a surface mark over there. So that almost concludes the cleaning and draping and also doing the initial surface marking with a C-arm in a patient on fracture table. Thank you very much for your attention.